Hello, my name is William Richheimer. I am the founder of the Mile High Eye Institute, and my goal today is to explain Fuchs Cornell Dystrophy. First, I'm going to start with a little bit of trivia. I think a lot of folks who are watching this video have already heard of Fuchs, but don't know everything about it. And the trivia question I'm going to posit is how to spell it properly. And I'll give you the answer. You can pause the video if you prefer, but it's Fuchs. And the really cute point of trivia is that there's an apostrophe after the S. So not important for your clinical knowledge, but it was Dr. Fuchs who described it, so it's his corneal dystrophy. And the full name of it is actually Fuchs endothelial dystrophy. And that may sound like doctorly jargon, and I think it is to a large extent, but it gives context to it, so I really want to explain what that means. So dystrophy is a word that implies that it's inherited and that it impacts both eyes. Now, our eyes are genetic twins, so it's not surprising that something that's inherited would impact them both. Now, the endothelial parts, Fuchs endothelial dystrophy, sounds a little intimidating, and it's certainly jargon, but I'll explain it. So I'm going to use myself in this clipboard as a prop. Imagine that I am an eyeball. My chest is the retina. My arm is the white part of the eye, also known as the sclera. And this cornea here is, this clipboard is the cornea. This is the clear part of the eye. So if you poke me in the eye, you're poking the clipboard here. Endo as a prefix means on the inside. Endothelium is a cell layer on the inside. So in my prop here, the endothelium is this piece of paper where I wrote the word Fuchs. That is the endothelium. And that's the layer that is imperfect, that gets impacted in Fuchs dystrophy. So to really understand it, it's helpful to know what the job of normal endothelium is. So I'll start by telling you, and this is a little bit dark, but when I'm dead, when I die years from now, my cornea will thicken up. It will get sort of waterlogged. And the reason for that is our eyes are filled with water. Think of, by analogy, think of a fish tank. Fish tanks have water on the inside, obviously air in the outside world. Our eyeballs are like that. There's water here, and there's air in the outside world. But when we're dead, the water can diffuse into the cornea, and that's why it thickens up. It gets swollen. And the job of the endothelium is to prevent that from happening. Now, where it gets really interesting is that this is not necessarily a mechanical barrier. Think of like saran wrap. That might prevent water from going through like a mechanical barrier. But an endothelium, it's actually a metabolic barrier. What I mean by that is this endothelium is burning energy, consuming glucose to actually pump water out. There's little microscopic cells, and they work almost like a bilge pump. Now that's something some viewers may be aware of, some may not. A bilge pump is something on the bottom of a boat that takes water. It may come in through the bow or through wherever, and it pumps water against the grain back into the ocean or back into a lake. Well, we have thousands of these bilge pump-like cells, which each have multiple pumps that are pumping water. So essentially our eyes and our corneas live in an equilibrium where fluid actually wants to diffuse in, but it's constantly getting pumped back out against the grain. And Fuchs represents a metabolic problem and a condition where essentially the horsepower of those endothelial cells and their pumps diminish over time. And so what happens is the cornea doesn't become waterlogged overnight. It's not like a light switch will flip and all of a sudden the cornea will get dramatically swollen. But imagine that someone takes a sponge and puts one drop in every month, and very slowly the sponge gets a little bit thicker. As Fuchs, because of our age and our metabolism can change, as Fuchs progresses, and because in Fuchs there's a genetic predisposition, the horsepower of the endothelial pump goes down over time. Very slowly, the cornea starts taking on a little bit more water. Now that's actually a little bit of an oversimplification because there's also a change in the way the endothelium looks. In my model where this is the endothelium, the healthy endothelium should be smooth. And in Fuchs it gets a little bit bumpy. The analogy I give here is almost like the pips you see on a less expensive table tennis or ping pong paddle. They have like little tiny bumps on them. The endothelium under the microscope starts to look like that. And we can see that with the photography that we take. There's a picture I use called specular microscopy that shows what the endothelium looks like. And for reference, this is a picture of somebody who has very healthy endothelium. They look like little hexagons, and there's just a high population density here. This is a picture, again, an example of normal endothelium. And then here's a picture of someone else's endothelium where it's impacted by the Fuchs. And these under the microscope look like little bumps. So as a consequence, when Fuchs progresses, it can negatively impact someone's vision in two separate ways. One is the edema, the waterloggedness, if you will, builds up. The vision starts to look foggy. Very typically it's foggy first thing in the morning and less foggy in the afternoon, but if it gets really significant, really severe, it can be foggy throughout the entire day. Again, that's because the cornea is carrying too much water. But the other way Fuchs can negatively impact someone's vision is because the little bumps that we see can actually scatter light, so it can cause glare. And for some individuals, the edema, the swelling within the cornea, the extent to which it's waterlogged, is the predominating factor. In fact, that's the most common. But there are some folks out there with Fuchs where the predominance of the cuttata, those little bumps, can really scatter light, and that is the predominating factor. Other folks, it's a combination of both. But the bottom line is that if the Fuchs progresses to the point where it's really having functional impact, where a person may not be able to do the activities they otherwise would enjoy, where they can't confidently drive at night, where they're really limited in some way, then it's reasonable to consider surgery. Now, the surgery in the old days for Fuchs was a cornea transplant, also known as a full thickness cornea transplant. And essentially in my model, think of that as getting a new clipboard. So this gets replaced, the eye is sort of open and dramatically so, and then we put in a new cornea and suture that with a number of stitches that go all the way across. Sometimes they're 16, sometimes they're more. And that is a surgery that is almost never done for Fuchs at this point. Cutting to the chase is just not as good. It leads to more problems and has a relatively high rejection rate. There's always a surgical seam that could open up with trauma. And it's associated with more problems. In the right situation, it can be a helpful surgery, but it's not considered the modern approach. The modern approach is known as endothelial keratoplasty. And now that you're familiar with some of the jargon involved, really what that means is essentially replacing the endothelium with someone else's. Now, it's still a cornea transplant, but what we call a lamellar cornea transplant, meaning a layer of a cornea and not the entire thickness. So essentially this layer, again, if the model of the eye is me, where my chest is the retina, the arm is the white part, and the clipboard is the cornea, what I'm doing surgically is removing this layer that has the damaged endothelium from the Fuchs. And then we use a donor tissue. And it's just a very thin aspect of someone else's cornea, so it's not the full thickness, and put it into here. Now surgically at first it's just kind of like this, and we use an air bubble. And the air bubble should push the cornea into the rest of the cornea, the layered donor cornea, and make it stick into place. And over time, these tissues sort of meld together. They're always separable, but they really stick in a dramatic and impressive way and give a better optical effect. And do so because they won't have the bumps in the cornea, because we can screen for healthy tissue. And if these cells stay healthy, which typically they would, the edema, the swelling in the cornea goes away. Now, if you're having a consultation, we can talk about the various types because there is more than one type of endothelial keratoplasty. And then you and your doctor, if it's me, we can talk specifically about the details of this. But as a summary, there's two main types. One is called DMEK. That's where the donor tissue is peeled away, and as a consequence, it's incredibly thin and typically comes in like a little roll, has to get unrolled in the eye, and then the air bubble may be a different gas, so there's more of a dramatic push on the eye. And because it wants to roll a little bit more, there's an association with this one of needing a second or third air bubble a little bit more. But in general, because the graft is so incredibly thin, when results do work well, it can be very dramatic and sometimes very impressive in how well it heals. And that one's called DMEK, DMEK, or decimase membrane endothelial keratoplasty. Now the other form is DSEK. Now imagine this is the cornea that ultimately is destined to become the donor cornea, so not the recipient. DSEK, the donor tissue, is not peeled away, but a thin section is made, so it's actually cut away. And as a consequence, the cut includes some of the substance of the clipboard itself and the endothelium. So it's not just endothelium, there's a little bit more rigidity to the tissue, and it tends not to roll up on its own. It has different structural characteristics. And as a consequence, when it goes in the eye, it has just a little bit more structure. And then I use an air bubble. This is called DSEK, DSEK, or decimase stripping endothelial keratoplasty. And then we use the air bubble to make it stick. And then the air bubbles typically with either one in the eye the next day, and sometimes even for a few days thereafter. But as long as that endothelial graft holds, whether it's DSEK or DMEK, typically the edema will clear away over time, and ultimately patients get better vision. Now, like any surgery, there's risk. And fortunately, the risk of immune rejection, which basically means your body recognizing the graft as being from someone else, is very low, is impressively low. For a full thickness cornea transplant, it's on the order of 20%. And in my experience with this type of surgery, it's much less than 5% risk for that. The risk of needing a second air bubble can depend on preoperative risk factors, so it's different for different individuals. And again, you should discuss this with your doctor based on your individual characteristics if you're considering one of these surgeries. But it might be a little bit lower in the context of DSEK, again, depending on the physician, depending on their preference. But in my hands, the DSEK has a very low need for second bubbles. But that's possible. If after surgery someone's graft is doing this, where it's partly attached, occasionally people need a second bubble, even with that DSEK, albeit not commonly. And then very rarely graft is just not right, where it's folded in a funny way or malpositioned. Or sometimes the cells, even though they were carefully screened preoperatively, are not as healthy as we anticipated, either because the donor had factors we couldn't fully account for, or because of trauma at the time of surgery or during the preparation for the surgery. But if that happens, fortunately, it's another surgery, but the tissue tends to be quite modular, and we can remove it and do the surgery essentially again with different donor tissue. And people often, if they need that second surgery, which is rare, still get a very good result. Now, that is not intended to be a complete list of surgical possibilities and surgical risk. That should be fully fleshed out with your physician. There's also risk of infection, retina problems, but fortunately, serious problems are rare. And thank goodness this technology and these surgical techniques exist, because for people with Fuchs Cornell Dystrophy who are having significant problems, most individuals who end up pursuing the surgery really have very impressive results. And whereas with the older form of full cornea transplant, sometimes it would be what I call a whack-a-mole proposition. You're trading one set of problems and improving it, but regaining a second set. Sometimes the new problems are worse. Most people with endothelial keratoplasty have outstanding results. So thank you for paying attention to this video. Please feel free to ask any questions if you're seeing me as a patient personally, but I hope it was helpful to you.